Hello, everybody, and welcome to Systems for Action's Research and Progress webinar. My name is Chris Lytle, Deputy Director here at Systems for Action. We're a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. And if we have any new viewers, we fund studies examining multi-sector collaboration across medical, social, and public health systems with the goal of improving population health and advancing health equity. Today we'll hear from an S4A project examining how the allocation of resources across medical, social, and public health services at the county level influences the relative success in controlling the progression of the COVID-19 pandemic. So we'll have a presentation from Beth Resnick, Carolina Cardona-Cabrera, David Bashai, who I'll give a proper introduction to in a second. Their presentation will be followed by Q&A. So if you have questions, be sure to add them to the Q&A box at the bottom of your screen as they come up. We'll have about 10 to 15 minutes at the end to answer those questions. So Dr. Beth Resnick is a senior scientist at the Johns Hopkins Bloomberg School of Public Health, Department of Health Policy and Management. She's also Assistant Dean for Public Health Practice and Training and Director of the MSPH program in Health Policy. Her research and practice interests include assessing and improving the public health infrastructure, enhancing knowledge of potential environment and health connections, and developing effective public health policies. Carolina Cardona-Cabrera is a PhD candidate in health economics in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. She works as a research assistant at the Bill and Melinda Gates Institute for Population and Reproduction Health, conducting research related to sexual, what's going on? To solve public health problems. Moving to the next slide, please. David Bashai. Dr. David Bashai was appointed as the health officer of Hartford County in January 2021. He was born in Tacoma Park, Maryland, and after attending Harvard College, received his medical degree from UC San Diego and his master's in public health from UCLA. He earned a PhD from Wharton Business School at the University of Pennsylvania, and later rose from assistant to full professor at the Johns Hopkins Bloomberg School of Public Health. And with that, I'm going to pass things along to our presenters for the day. Don't forget to add questions to the Q&A box as you have them. Thank you.
Great. Thank you so much, Chris. And thanks for having us here today. We're very excited to talk about our work. Normally, our work is always important to us, but not always, everybody doesn't always necessarily pay attention to it or worry so much about how public health systems are structured and financed and the effectiveness of public health systems. But obviously this year, we really have a moment, not only about COVID, but about public health overall and social justice and equity issues that, again, we have been looking at in our team for a long time and appreciate the support for S4A for our work over these past several years. So I'd like to call everyone's attention to what we're going to be talking about today, but also sort of the larger picture of the importance of this work. And I'm Assistant Dean for Public Health Practice. Dr. Bashai is now the health officer in Hartford County, Maryland. So the application of this work to how we're actually responding to COVID as well as ongoing public health challenges are super important. So we're looking forward to talking more about that in our Q&A session and sharing some of the work we've done on some other topics as well and the importance of this public health systems research. So specifically for our agenda for today, we are going to be talking about the social epidemiology of COVID-19 and looking at some of these key questions that maybe all of us have kind of been thinking about over this past year. Did past county and state level public health spending actually improve early COVID-19 control in 2020? Seems like that was a long time ago, but when this pandemic first started, were the people that were funded better more equipped to be able to respond? And then ultimately, we've been talking so much about the failures, but we actually are flipping that and trying to find the positive deviance in terms of counties that were actually able to be more successful in COVID-19 control. And then our aims moving forward about what might be factors that could contribute to success and how can we learn from this when we think about rebuilding our public health system. Next slide. So what is our strategy? And this is what Carolina and Dr. Bashai will be talking about in more detail. We had 3 aims. The first one is developing the metrics for success. So how are we defining what success is at the county level for controlling, responding to COVID-19. Then our aim 2 was we use statistical analysis to adjust for obvious pre-existing advantages. So when we're trying to look for which counties maybe did better, obviously those that maybe were younger, richer, and whiter would have an obvious advantage, right? So we're trying to look at counties who did better than expected based on their relative advantages. And then 3, the going forward part that we're really excited to get your input on is having some key informant interviews with those counties that did do better to think about what are those underlying factors, structural factors, alignments about why they might have done better and what can we learn from them. Next. So I'm going to pass it off to Carolina to go into the detail of the social epidemiology and all the other pieces I just said on our agenda. Thanks.
Thank you, Beth, and thank you all for participating of this presentation. So I am going to share with you the first section of this presentation where we're going to share some preliminary findings of our study that is looking at the social epidemiology of COVID-19. I'll start by providing some background information and focusing on the motivation for conducting this research. So what we've learned so far throughout the pandemic is that the social determinants of health can have a considerable effect on COVID-19 outcomes, both in terms of cases and also in deaths. And we've also seen that the mechanism of how this enacts is at the individual level, and that individuals with a higher social vulnerability were the ones that suffered the most. We've also seen in the US that at the county level in 2020, counties with the majority of Black population registered a COVID-19 infection rate that was 3 times higher than counties that were majority white. And in terms of COVID death rates, we've seen that the counties that are predominantly Black, they registered a mortality rate that was 6 times higher than counties that were predominantly white. We've also learned throughout the pandemic that individuals that rely on low-income occupations, they had a harder time to practice physical distance. And we've learned so far that physical distance is a key measure to controlling the spread of COVID-19. We've also learned from 2020 that housing insecurity increases or it leads to a mix of negative health outcomes. One example is that it was found that school closures were associated with increases in food insecurity for children that rely or participate of school lunch programs. But what we want to know now is, so we know that the social determinants of health are affecting COVID-19 outcomes in terms of at the individual level, but we want to know if that is also true and if it also holds when we do the analysis at the county level. And if that is the case and that we're able to identify that that is happening, we wanted to identify if we can identify counties that are more resilient or less resilient, and if we can also identify counties that perform better than predicted given their socioeconomic characteristics. To do that, we collected data from approximately 3,100 counties. And in this particular study, we focused on COVID mortality, not in cases. And we retrieved data for this 3,100 counties from the New York Times repository using all deaths that were registered between January 21st of 2020 until February 20th of 2021. We were also interested in comparing the relationship between socioeconomic characteristics and COVID mortality, and if that relationship is the same between socioeconomic characteristics and all-cause mortality. So we retrieved data for all-cause mortality for the same group of counties from the CDC. And then we also collected a bunch of socioeconomic characteristics from both the Census Bureau and the CDC. As for our methodology, we first started our analysis by conducting simple OLS regressions in which we focused on 3 main outcomes. Our first outcome was all-cause age-adjusted death rate. Our second outcome was all-cause cruise death rate. And then our third outcome was a COVID-specific cruise death rate. And we regressed each of these outcomes into a bunch of different socioeconomic variables. And each of these regressions were conducted separately. Once we had our OLS regressions, we did a separate analysis in which we wanted to be able to categorize counties into different strata in order to have stratifications of counties where the counties within each of the stratums, they would have similar socioeconomic characteristics, but different socioeconomic characteristics across a strata. We wanted to do this categorization with the goal of being able to find performing counties that are performing the best within each of the stratum. To do that, the stratification, we implemented a coarse and exact matching method. I will now present some of our preliminary findings. What you're seeing on this slide is a simple histogram of the age-adjusted death rate for the US that was registered in 2020. What you're seeing here is that all-cause mortality adjusted by age follows our normal distribution. And then on this slide is the same all-cause mortality, but it's not age-adjusted anymore, it's the cruise rate. And you can also see that it also follows a normal distribution. But then we also plotted the COVID-specific cruise death rate, and we noticed that the distribution of COVID deaths did not follow a similar pattern as to all-cause mortality, and you can see it has a long tail. So because of these patterns, then we were wondering if we may find different results when we look at all-cause mortality than when we look at COVID mortality. So I am now going to share what we found from our simple OLS regressions. On this table, what you're seeing is a simple OLS regression of each of our outcomes regressed on 5 different socioeconomic variables that are measuring the revenue per capita at the county level, the percentage of the population that are above age 65, the percentage of Hispanics, the percentage of African Americans, and then the median household income that, all of this are measured at the county level. In the first column, you're seeing the regression when our outcome is all-cause age-adjusted death rate. And what you can see here, and what we care about this table, is that we can see that these 5 socioeconomic characteristics are able to explain around 46% of the variation in all-cause age-adjusted death rate. And then when we do the same regression, but instead of using the death rates adjusted by age, we just looked at the cruise death rate for all-cause mortality, we can see that our 5 socioeconomic characteristics are able to explain up to 64% of the variation of all-cause mortality. However, we were expecting to find a similar pattern for COVID mortality. However, when we do the regression using COVID cruise death rate as our outcome of interest, we find that these 5 socioeconomic characteristics are only able to explain around 8% of the variation of COVID mortality. In the third column, we did the same regression with COVID as the outcome, but we allowed to include past mortality to see if past mortality would increase the explanation of COVID mortality. And we noticed that it only increased by 1%. So this was surprising for us. And we were expecting actually that socioeconomic characteristics would explain a similar percentage as it does explain all-cause mortality. So once we, in our second part of our analysis, where we wanted to stratify counties, because remember that the prior slide was showing the regression for all US counties. But because we find that pattern, we ask ourselves, so what happens if we stratify counties into different strata, where we know that within the stratum, the counties have similar socioeconomic characteristics? If we control for that, if we were going to be able to find a similar pattern, or if we were actually going to be able to find that socioeconomic characteristics can explain COVID mortality. So with the coarse and exact matching method, we were able to categorize around 2,800 counties across 12 different strata. This classification was done accounting for revenue, age, race, ethnicity, and income. And in each stratum, we set up to have at least 40 counties. So that's also why our sample gets reduced a little bit. I will now present some of the key findings from our stratified analysis. What you're seeing here is what we were expecting to find. In this slide, we have a box plot where we are plotting the all-cause mortality cruise death rate, which is depicted in the y-axis. And then in the x-axis is each of the stratums. So the box represents what the median cruise death rate was within the stratum. And what we were expecting to find is that the cruise death rate within each stratum should be different when we compare the strata, all the different strata. And that is what we're finding here. We see that the boxes are not overlapping between them. And we also included in this graph a line in the middle of the graph that is representing the median value of the US. So we were expecting that the boxes would be distributed either above or below this line and not overlapping. And that's what is happening with the exception of stratum 3 and 18. Something I forgot to mention in this slide is that we are looking at those counties that we were able to rank and that were part of the highest quartile. We did the same analysis with the ranking and showing the counties that are part of the lowest quartile. And our intuition or the pattern that we find is the same, where we're seeing that the boxes are distributed either below or above the national median. However, when we go and do the same analysis, and instead of looking at all-cause mortality, we look at COVID-specific mortality. This is a similar graph as the above, except that we're looking at COVID mortality, and we're focusing on looking at the counties that are part of the highest quartile. We see that the boxes are overlapping between them. We do not find the same difference as we did in all-cause mortality, because remember that we know that across the strata, the counties that are within each of these stratum, they have different characteristics across them in terms of socioeconomic characteristics. So we would expect that their mortality should be different as well. But that is not what we're seeing in terms of COVID. We're seeing that their COVID mortality, it's actually quite similar. We did the same plot for the counties that were part of the lowest quartile, and the same is happening. We see that the boxes are overlapping. So what we're finding here is that even though we know that these counties have different socioeconomic characteristics across the strata, we're finding that their COVID mortality is quite similar, which is something that we were not expecting to find. Once we saw those patterns in terms of mortality, then we wanted to know if our strata was doing a good job at explaining the variation in mortality. So what you're seeing here is a regression of each of our outcomes into our stratum variables. And we find that our strata classification can explain up to 21% of the variation of all-cause age-adjusted death rate. When we look at all-cause mortality cruise death rate, we see that our stratums are able to explain up to 40% of the variation. However, when we go into looking at our COVID mortality, we find that our strata, even though they're doing a good job at explaining all-cause mortality, they're only able to explain 4% of the variation of COVID mortality. So based on that analysis, we can conclude from this first section that the social determinants of health have a weaker effect on COVID deaths at the county level than at the individual level. Keeping in mind that this does not negate the effect of social determinants on COVID at the individual level that we've been seeing throughout the pandemic. We also find that age, race, ethnicity, income, and revenue were able to explain only a small portion of the variation of COVID deaths, even though they were explaining a large variation of all-cause mortality. I will now hand it over to David.
Thank you. Can you hear me okay? Carolina, can you hear me? Okay, good. So now we're going to ask the question about whether spending in the public health departments of the country gave the county health departments resources that they could use to do the immediate response to an outbreak. That's why one of the main reasons we have health departments is to detect and wipe out outbreaks fast. They're kind of like the first responders to the nation's outbreaks. So it is valid to say, well, did their funding from the past give them the ability to respond? Next slide. So the trouble was that early in the pandemic, there was not a lot of success. We found that only 26% of counties were able to bend their curve. And we defined bending a curve just as having the level of the cases per 100,000 have an inflection point where the slope went from rising to flat to falling within that space of the first 6 months of the epidemic. We're asking the time to achieve that control of COVID, that first response to bend the curve, we hypothesize that being a strong health department would help you do that better. So that's the main question. So the pie chart is showing you that in the red segment of the pie chart, only 26% of US counties had a success. That means that only those 26% of counties had a time to success variable. We'll be looking at that red segment's time from the start of their pandemic, defined as the 10th case, to bending the curve. All of the other segments, the green segment that really didn't have COVID in the first 6 months, or the blue curve that didn't get control, they're not under study right now because the time for them to succeed has been right censored, and we don't get to look at that. Next slide. So we're looking at the first 6 months. Obviously, now it's been 15 months and we're still wrestling, but by now the county health departments have been able to access CARES Act funding, supplemental funding. That money has gone out based on politics, based on strengths and weaknesses. So studying control in 2021, certainly your money in your health department in 2019 really is becoming more and more irrelevant because county health departments have been rescued in a way and have had the ability to make contracts with outside vendors. And we don't have state of the minute, up to the minute data on where the health department's money has come from and how much it is. We won't have that picture, that financial picture, for a long time to come. So we're going to be studying time to event models. The start of the clock is the 10th case. The end of the clock is the time when your curve bent. And we'll also do other analysis about what was the peak incidence when you did bend your curve, how many cases were you having per 100,000? And if you never bent your curve, how fast was your epidemic doubling? So the reason we're focusing on the time to case bending is that's what we want the health department to do. Crush the epidemic fast, stop the outbreak, stop the transmission, interrupt the transmission. That's what public health was supposed to do, and it was supposed to have the muscle to do that, the capability and the flexibility to detect and respond. The way they would respond was to do behavioral change, to modify their citizens' mobility patterns, behaviors, social contact. Counties that had that capability, that had gained the trust of their citizens, would have been more successful, but they couldn't build that from scratch in January of 2020. They needed to have building that muscle for years before. So bending a case curve means behavioral modification. Bending a death curve requires modifying physician and care provider behavior, shifting the demography of cases away from the high-risk groups, protecting the nursing homes, and getting the medical community geared up to learn fast what the latest practices were in COVID control. Next slide. So this is the picture. We've seen these curves, but just so you see in the blue, this is a bent curve that has, you can see it starting to have a second wave at the right. This is from Butler County. And you see them reach a peak COVID on, it looks like June 20th. So their time to the peak would have started at their 10th case on the left, and we would have counted the number of days till their peak. If you look on the right, you'll see Calhoun County, and in the first 7 months of the epidemic, they didn't reach a peak, so they're right censored. Hopefully by now Calhoun did bend their curve, but we're not looking at the end of 2020. We're only looking at the first 6 months. Next slide. So the right-hand side variables that we want to study are the county level spending on health. Now, county level spending on health is going to come from the census. The census gives you health spending in two buckets. There's spending on county hospitals and city hospitals, and the non-hospital health spending, which is a fair amount of public health spending, but other things get mixed in with non-hospital spending. For instance, mental health service provision that's not in the hospital, STD control, tuberculosis, some clinical services get mixed in with that, as well as good old-fashioned contact tracing, epidemiology, and responding to outbreaks. So it's a blend of many things, but it is an indicator of public health spending. We have information on county level public welfare spending. We have the state level of public health spending, as well as the targeted public health spending at the state on communicable diseases, as well as on hazard preparation. And so we're going to use those key dependent variables and obviously put in some control variables. Next slide. All right, so here's the results. And again, these are multivariate models. We don't have the room on the slide to show you all of the traditional controls, the demographics of the county, the age profile, the racial profile, ethnicity, schooling of the county, the overall income level and unemployment of the county, all of the things you would have wanted, those social determinants that you would have wanted, they're in the background here. But we've put around a blue rectangle to test the main hypothesis. Did the public health funding in the counties, was that really helpful? And you'll see that there are no asterisks on that variable. It was not statistically significant. The direction of these variables are the dependent variable is the time to success. So we want that to be short. We want fast success. So when the coefficient is less than 1, it means it was good. That county health spending at 0.983, it shortened it relative to the average, but it wasn't significant, and 0.98 is not much shortening. The log county revenue per capita, you'll see it in Model 1. The counties that had lots of money, they were rich counties, just having lots of county money in Model 1 seemed to have an effect at 0.449, cut in half the time to event. But as we enrich the models up towards Model 2, 3, 4, 5, 6, we're adding more and more social controls. And by the time we reach Model 6, we've added age and income levels and unemployment and schooling. The county revenue loss is significant. So by the time we're in Model 6, what the county governments did and how they spent the public health money had no correlation with the time to the control of COVID-19. We'll come back to discussing that, the findings meaning. When we put in state level variables, in addition to all of the traditional controls, good job, state health departments. So no matter what the state spent per capita in the first row, that wasn't statistically significant, but the more a state had been spending on hazard preparation at the state level, and obviously doing a lot of that state spending down at the counties, but we knew it at the state level, that was very protective. And it shortened the time, the odds ratio is 0.6 for reducing the time to reach the peak. So state hazard preparation was a policy variable that we found evidence would shorten the time to COVID in the first 6 months of the COVID pandemic. We found that when we put in hazard preparation and state spending on communicable disease control, the communicable disease control spending, typically the reportable diseases, STDs, rabies, the rabies and TB and STD money didn't seem as related, wasn't statistically significant, but hazard prep spending at the state level was significantly associated. Next slide. So no statistically significant association between historical county public health spending and rapid control of COVID-19 in the first 6 months of the epidemic. But state level spending on hazard preparation did shorten the time to control the COVID pandemic in our data set. Next slide. So if we want to give you a take-home point, I know I'm in a health department. I would love to take these results to the governor of Maryland and say, Governor Hogan, look, give the health department money and we will shorten your time to your next pandemic. I don't have the evidence for that. I should say to the governor, whatever our health departments in the counties were doing in January of 2020, doing more of it didn't seem to be related to their ability to crush COVID. And we have a lot to tell you about why the money that health departments were spending seems irrelevant to the flexible and dynamic control of an emerging pandemic. That is the part of the public health infrastructure that we must all talk about to change so that if we get another pandemic, we won't repeat what I've just shown you. So the second bullet says, I think the system doesn't just need more money. There needs to be purposeful restructuring to give us the flexibility to do the things that need doing. Now, there are limitations in the result. There was a 2-year lag between when we knew how much money they had and the pandemic. So maybe in 2019, there was this major change in county health spending. I know some of us who know health department budgets know that that actually didn't happen. 2018 spending was very, very tightly correlated with 2020 resources on hand. And we didn't look at COVID-19 outcomes at the end of 2020, but as I've explained, the money you had in the past became irrelevant after CARES Act money and supplemental funds came in to really change what the counties had at their disposal. Next slide. All right, wrapping up in this last section for us on this work of what we want to do, we want to find those counties. You saw that there were 26% of the US counties did crush COVID very quickly. Within the first 6 months, they put out the fire. We wanted to go through identifying the ones that did better than expected. So let's go through the results in this analysis. You saw how we've identified, we looked at the COVID curves, we've measured the time between the 10th case and the bending of the curve. So those same time to event models that I just showed you can help us find the ones that did better than expected, did better than their age and race and schooling and incomes would have predicted. And we're going to look at the topmost deciles. We're going to call them positive deviants. We want them to tell us the story. We want to tell all the other slow counties, what did it take to be a winner? What did it take to put this out really fast? Next slide. So back to echoing what happened in the first 6 months. If you look on the right, you'll see what I said before, that in the blue, you see that only 26% of US counties were really able, back up. This is data not from last summer, but from no, go back to the pie charts. There we go. By February of 2021, we had found that there'd been a lot more success in America. We'd found that there'd been only the orange segment on the left were counties that had achieved no bending of their COVID curves. But there were many other versions of bending your curve as of February of 2021. In the blue on the left is bending of both cases and death curves. In the red, counties that had bent their case curve, but not their death curve. In the green, we still found some counties that had the death curve come down, but cases not come down. And we've been very curious about how do you bring your deaths down in the green cases, but nothing else. And we found in the orange that there were still counties that have not achieved any bending of the curve. When we look at cases only, the red segment on the right is the counties that had any type of bending of cases. So by February 2021, the country is more successful. There are still some places in America that have not gotten their curves to bend. Next slide. All right, so now we are going to go through how we go about finding the positive deviance. The horizontal axis here is the time to bend the curve, time to reach an apex. And so you see on the left of this, it's a very, very thin. There's just not a lot of dots. And we've circled in red the counties that are doing that, bending the curve in the first 100 days. We're now on the vertical axis is the deviance residual, which means the higher you are, the more exceptional you are, the more you are doing better than expected. So the highest vertical height in that red circle are the exceptional positive deviants. They're doing better than expected, and they're crushing the COVID epidemic very, very quickly. And we can pick off those red circled counties. Now we're going to stratify by urban and rural. And if you look on the right, you'll see that top left tail where there's speedy control, you'll see a lot more of them in the urban counties. And at the bottom right, you'll see, sure enough, there are some success stories in the rural counties. They're just not as many getting it done in the first 100 days between the 10th case and the bending of the curve. But our strategy for finding our positive deviance is to ask, did you do it fast? And did you do it fast? We find by finding you less than 100 days. And did you do it better than expected by finding you very high on the vertical axis is doing it better than expected? Next slide. All right, so now we want to look at our speedy guys, our top performers circled in orange. We're showing you our topmost decile, and this is just describing their characteristics. So if we want to know the characteristics of the fastest 159 counties, they're more rural than the other counties. They're 77% rural, as opposed to the comparison group, which was 55% rural. The density, they were less dense than usual. The testing frequency was higher than usual. They were more likely to have, their average was 3.17 tests per thousand, and the comparison group had 2.2 tests per thousand. The speedy top performers were had a less prevalent Hispanic population. They had a less prevalent African-American population. They had a slightly less percent under 18 and a slightly higher percent over 65. So this is just starting to give you a little bit about the factors that went into being a positive deviant. It's a looser way to do what the regressions were doing, but it's giving you some rough ideas about where these positive deviants were and what they looked like. Next slide. We put in other variables about these positive deviant counties. We know that they seem to have slightly higher college education, though you can see from the standard deviation that that's not going to be statistically significant. They had about the same amount of food insecurity. They had a little bit more uninsured adults, again, not statistically significant. They had pretty much the same active number of primary care physicians per 100,000. A little bit more smoking, a little bit, really not a whole lot going on obesity and smoking. So comparable in these behavioral risk factors. Next slide. Okay, going over more comparison between these counties in the topmost decile and the others. We see that their spending on public health, circled in the red, was slightly higher than the average. But we've already been, our better answer was in the regressions I showed you 15 minutes ago. The better answer really doesn't group them into this decile. So even though you'll see that, yeah, they look like they spend a couple $100 more, that's not statistically significant. So this method of telling you about them just is a rougher estimate of what was true about the positive deviant counties. What I hope you'll take back is just looking at quantitative data about the positive deviants really doesn't tell a compelling story other than being rural and being less dense, if anything. So the team is getting IRB approval. We might actually already have IRB approval, and Beth will tell us one way or the other, to go out and call the positive deviants for more in detail qualitative data about how was it that they were able to be so good at COVID control so quickly in 2020. Next slide. So we're going to select our top performers. We're developing our interview guide. We're developing our list of key stakeholders to interview. I, as a health officer, someone called my phone and said, hey, Bishai, we'd love to ask you your success story. I think I'd pick up the phone. So we're hoping to get not bad performance, because it's not the phone ringing with just another complaint and another attempt to ridicule and harass. I think this would be a positive experience for our subjects. Next slide. I think I'm going to turn it over to Beth for the next steps. So let's put Beth back on.
Great. Thanks so much, David and Carolina. So we really look forward to talking to you all. I know there's a couple questions in the Q&A already. And again, my thought on some of our key points about we can't just throw money at a subject, but really thinking about public health and restructuring, particularly at this moment in time when we're all thinking forward post-COVID, how do we rebuild the public health system? And we want to avoid the pattern of rushing to spend money and then all of a sudden going back to the pattern of neglect. And actually, we have a couple articles that I think S4A group is going to post in the chat. One in particular that was in Health Affairs by Natalia on our team, that basically the funding of public health agencies has been neglected for the last 10 years. We also have some other papers that we've done looking at, for example, public health law spending versus, law enforcement spending versus public health spending, other topics of interest. And additionally, a larger question about public health systems research, like we were just sharing here with you today, and our thoughts moving forward about the importance of this type of research. So look forward to hearing your discussions. I guess I will first start. There's a couple more specific questions, Carolina and David, if you can see them in the Q&A, and you want to jump in on that.
So I can take Linnea's question. Thank you, Linnea, for thinking through including and not including testing. I remember back, we all remember how it was back in February and March. And in the early epidemic, not just in counties and states, but in countries, a lot of what was driving the numbers was the testing. And that even reached the attention of our president, who said, look, why are we doing all this testing? It just makes us find COVID. And so early in the pandemic, there was so much heterogeneity in the availability of testing that was driving the COVID. We felt it would be better to clean the case counts with a right-hand side control for the amount of testing, so that it was controlling for testing how much COVID did you have. And early on, that testing, later on, it became very useful. And nowadays, the more you test, the more you actually have the ability to use the testing information for contact tracing. February, March, April of last year, the testing was just for us a statistical way to watch those curves be real COVID as opposed to the testing on COVID. Now I can assure you, Linnea, that Carolina has run so many models that with and without that testing data, our main conclusion that the public health budget from 2019 is uncorrelated with the COVID result, that's going to hold up. But I think we'll have to mention that in the paper, that there's another way to think about it, which is that the testing count should have been a left-hand side variable. Did your past spending allow you to test? The reason that we hesitated with making it an outcome was that health departments were one of many ways to get tested in the spring of last year. And a lot of the testing happened more at the hospitals and clinical settings.
I can take some of the questions that were asking about the variables that we've included. And also adding to the testing thing is that the data were not available at the county level. They were just available at the state level. So that was another restriction that we had in our analysis. There was a question about including counties that are in the Indian Health Services. So we've included all counties that are classified as rural by the USDA. So our answer would be yes. And in addition to testing capacities, we wanted to consider hospital capacity. And the best proxy that we were able to find at the county level available was number of physicians per, I think it was like 100,000 people or 10,000 people. I'm not exactly sure, but we've included physicians. And so far, we did not include at the social vulnerability index from the CDC, but we did account it for a bunch of different socioeconomic characteristics that are part of, or that are variables that are part of that index.
Great, and I can answer the question about the interviews, and if people have other thoughts about what we should ask in the interviews, I'd love to hear that, because we do have IRB approval and we're going to be starting on that next. We did consider also interviewing the lowest performing counties, but we thought, as David was talking about, you get a phone call and someone says, hey, you were ranked the lowest. We didn't think that they would necessarily want to participate. In addition, we also thought that it would probably be difficult to find people, and likely that would contribute to the low performance if they didn't have strong governmental presence, even in the health department or in other arenas. So we did think about that, and we will definitely look at some of the structural pieces we can find through our data analysis between them. But we didn't think it would be most productive to interview them. The next one, I know it was directed to David, but again, about % of the positive deviants are accredited public health departments. Yes, absolutely. We are going to be looking at that. And again, that would be something that we'd be thinking about in the qualitative interview process.
As far as the SBI goes, I mean, the first segment, or segment 1 of this talk, showed you the real. I'm still puzzled by why the R-squared on our age and income was so weak at predicting COVID. And so anonymous attendees' suggestion of using the SBI would be great. And I think we should rush in and do that. And again, I know the SBI will predict all-cause mortality. Given what I've shown you today, I don't know what'll happen. Will the SBI be similarly weak at predicting COVID? I've been thinking about why did this list of usually successful social variables do so badly at predicting COVID mortality? So Sergey's question is that public health is a labor-intensive business. And the workforce variable is available in the health department. There is a file full of the health department staffing. We made a choice to use the money and not the workforce. And Sergey's suggestion is we go back and put in the count of the staff in the health department, which is reasonable suggestion. We know it's correlated that the dollars don't spend themselves. The number one use of the dollars in a health department is labor. So they will be correlated, but it's we're going to come out with a null finding that health department resources from the past didn't predict success. Better to make it stronger and do what Sergey's suggesting and use the workforce variable at the counties and see what that shows. That's a great idea.
Just to add into that a little, David, though, it is very messy because all different health departments are structured so differently, especially at the local level. So your number of employees might be more having to do with what services are offered in your department. For example, if you're offering direct healthcare services that aren't available in your community. So that number can be a little bit misleading at times too. And there isn't really one good place to find that number either. So that can get a little messy. And a lot of health departments are not set up by county. So you can have regional or district health officers, so offices. So it can get kind of messy. Good point, Lisa. Do we have to call up and say, hey, you're the lowest performing when contacting? That is a good point. Although, you need to be transparent, right? So we'd have to show them some reason why we selected them. So, but you're right, we might be able to be creative and think about that. But again, I think what we are focused on is why the ones are really successful. And then maybe after those interviews, we could then go back and look at these lower performing ones in more detail and do some comparisons. So you're right, we don't have to say never ever, it could just be right when we're starting, we're going to start with the positive ones.
So Michael Stotos, Michael, hi Mike. Your question is the one that we know we're going to get again and again, and it's important to address it now. We've all, we're in April 2021. We know there's been 3 or 4 waves, and we would love to ask what it was that allowed a county to be successful all the way down until, vaccine phase of this. And, I'm telling you as a health officer that my vaccine game in 2021 has very little to do with the money this health department had in 2019. I am now flush with millions of dollars that I'm getting from the feds and the state. I can't I mean, I should be driving a Mercedes, frankly. It's just so crazy, all the money. But so that our hypothesis, and again, for policy, we're going to try to tell the governments of the world in 2025, this is why you should spend for the health department, because an epidemic might come next year. And our hope is that they will control it like any outbreak, like any disease that's coming into your city, like Jon Snow, right? So Jon Snow says, oh, I got cholera, let me take the handle off the pump, and he solves it. That's what we want our health departments to do based on the money they got the year before. Now, if that cholera epidemic had gone on Broad Street for 2 years, there'd be way more Jon Snows in Broad Street, and it wouldn't be spend money and get one Jon Snow per street. So we're really trying to ask the question of what do you spend when nothing's happening, and how does that protect you when the crisis comes? We really want to write that in our paper as clearly as possible. The second point about the death counts is important. And I think the answer to that is to try to use the latest and greatest vital registration data that we can get, and perhaps use excess mortality as an indicator in that analysis.
So David, I just wanted to add on to one thing that you were saying, because it kind of relates to our bigger question about public health systems research, and also trying to get out of the pattern of, okay, let's just rush in and throw money at something once it happens, versus being prepared in advance and having the systems and infrastructure in place that you can address not just a pandemic, but whatever the challenge might be in your community. So again, looking at it afterwards when people have thrown a bunch of money at it is a very different question than what you were talking about when you first started. It's sort of like looking at someone's wealth after they won the lottery, but not looking at it initially in terms of how can we assure that we're ready for whatever it is we're taking on, which again is the importance of that public health systems and services research, which hopefully within our S4A group, we can have additional discussions on going forward, because I think it's key when we think about rebuilding the public health system.
And also adding to that, the reason of why we focus on the first wave and not on the other waves, as we've getting in some of the question, is because in the first wave, we're able to capture how past public health or preparedness of public health departments has helped us to control COVID-19. But if we look at current second or third waves, we wouldn't be capturing that, because people had learned from the first wave how to change their behavior. And maybe they were also given extra funding. So we wouldn't be able to capture preparedness if you look at current waves. So that's why we focused on the first wave.
So I see the last couple questions. I think about what Carolina just said, which was that, you know, the timing of these subsequent waves doesn't line up. To the point that counties are using federal funds to enhance public health infrastructure. Absolutely, yes. We are definitely trying to think beyond it. My big COVID money is supposed to end on my fiscal year at the end of June. But I've already brought on new staff that will give me muscle for the future. I brought on community health workers to reach out to my minority populations. We brought in epidemiology consultants to give us muscle on studying our mortality and morbidity data. And we're going to hopefully retain much of that. But all of this I have to justify as COVID. I have to say my CHWs are COVID CHWs. My epidemiologist is a COVID epidemiologist. And in 2022, I don't have a budget for them. And so if we repeat a pandemic in 2025 and all of our COVID stuff goes away, I mean, we did this in 9/11. We all got our preparedness money and brought preparedness things. And you would have thought that, you know, that was just 20 years ago. It's all gone. It didn't last. Moreover, the big elephant in the room is the structure. Why was a health department so bad at COVID control is the silos. Let's please remember the silos in public health spending. Every dollar I spend has a disease's name on it. I have people who are STD people and WIC people and mental health people. Every dollar has a disease on it. And so you get a brand new disease and there's no dollar for it. I have to move STD people and make them into contact tracers and epidemiologists. And the state says, spend this money on this disease, spend that money on this disease. I don't have the flexibility to go out. Nobody's paying me to build partnerships with my community members. Now they are, to get them to get a COVID vaccine, but this wasn't what we did, only if it would help me run a WIC program. So I have WIC community outreach. So the local health departments, as well as the states, it's this hierarchy of bossing around, where the feds say to the states, we have the money, do what we say. The states say, we have the money, counties do what we say, always with well thought through top-down vertical programs. But the muscle on the ground, the ability to say, oh, there's something new over there, let's go and help the community figure out what to do about it. That's the muscle that is not in a silo. And in going forward, building that muscle, building that ability to respond, the flexibility, the dynamism to go and do what's necessary is so important. Imagine your doctor saying, well, you know, I know you're here for problems breathing. I can only help you with syphilis. So forget about anything else. It's a syphilis hospital, right? That's kind of what we have in public health. We have tied down money. And furthermore, as Beth was saying, the research community that used to be supported to do public health systems and services research has been sort of abandoned by traditional sources of funding. And it would be lovely if we got sponsorship by the federal government, CDC, NIH, AHRQ, more foundations than just RWJ. Why is it that only RWJ is really listening to this community? I think if I was a billionaire and I was seeing COVID, I would be spending on this.
Great points, David. And you just told us you had millions of dollars, so maybe you can fund some. But I think what we are really thinking about is long-term, and it's great to have this forum, and I want to thank S4A for giving us the chance to have this discussion and appreciate all the input. Chris, turning back to you.
Yeah, thank you, David, Beth, and Carolina for sharing your work and bringing us home with this thoughtful conversation, really helpful analogy that we can, no, we don't want any syphilis hospitals. That makes so much sense to me. So with that, I'm gonna run through a couple announcements to bring us all home. If you would like to receive a certificate of completion for today's webinar, complete the survey at the end of the session. We'll also email you one. So if you're interested in more collaborative, cross-sectoral collaborative work, such as the JHU team that you just heard from. We do have a funding opportunity that is currently open, and we have an informational webinar, so you can learn more about that with an extended Q&A session on April 27th, 4 p.m. You can sign up for that on our website, systemforaction.org. And other funding opportunities with our partner organizations, Health Equity Scholars for Action is a new program created by the Robert Wood Johnson Foundation to help support the professional development and career advancement of historically underrepresented researchers. And this includes funding, mentorship, and community support opportunities. That deadline is June 16th. We also have a funding opportunity coming from Transforming Health and Healthcare Systems research program. This opportunity is focused on the impact of recent Medicaid policy changes on enrollees, states, and others, and to inform and advance health and racial equity in Medicaid. That deadline is June 28th, 2021. In our upcoming webinars, we have our first Systems in Focus panel. This discussion will be addressing the housing crisis through systems alignment, and we're focused on COVID-19 and beyond. So this should be a great conversation. If you want to see more webinar opportunities, those are also on our website. as well. So hopefully we'll see you May 5th, same time, same place. Hopefully we'll see you there. So thank you again to JHU team for sharing their work and bringing this timely conversation to the Inspire audience. Enjoy the rest of your day, and then hopefully we'll see you in May.
Great.